Cameron, thank you very much. Well, it's a pleasure to be here this morning. And despite the incredible advances that have occurred in the field of HIV, this is a disease that still is a major problem in the United States. And what I'm hoping to do to convince you this morning is this problem has not gone. There's still a lot of work to do. And I'm going to focus this on some key issues really at the level of the internist and the primary care provider, focusing on key aspects of diagnosis, treatment, and prevention for HIV here in the year 2015. I'm specifically going to be addressing these 5 topics: the epidemiology of HIV, what's new in there, the HIV testing and new diagnostic testing algorithm that was issued in 2014 by the CDC, really antiretroviral therapy, what's new in that, but really for the internist, how do you actually understand how all of these drugs work? It seems so overwhelming to people when you hear about these more than 25 medications that are out there, all these different classes. So I'm going to step back and try and give you a framework for how the drugs actually work so you can visualize that. Then I'm going to address the issue of timing of antiretroviral therapy, which has changed dramatically in the past 10 years in terms of when we're starting antiretroviral therapy. And it's very important to understand the rationale, why we're doing this completely different now than we were 10 years ago. And last, a newer concept in the field of HIV, something called pre-exposure prophylaxis, or PrEP. I'm going to touch on that. So let me begin by diving into epidemiology. It's very important to understand who's living with this disease and who's getting the disease. Now, in the United States right now, there's an estimated 1.2 million people that are living with HIV. Among those living with HIV, approximately 3/4 of them are male and 1/4 are female. If you look at the risk factors for who's acquiring HIV and who's living with HIV in terms of their risk factors of what they had when they acquired it, more than 50% of people living with HIV acquired HIV through male-to-male sex. Injection drug use now, only about 15% of people acquired it through injection drug use in this country. And heterosexual acquisition was about 18%, or 1 out of 5 people, are women who acquired HIV through heterosexual sex. Now, this is a very interesting graph. If you look at the top bar, this is looking at the prevalence rate. So this is the number of people per 100,000 population. The prevalence rate is very, very concerning. When you look at this, you can see that blacks or African American have by far the highest prevalence rate in this country, and it's approximately 6.5 times greater than the prevalence rate in whites. If you look at this graphic, the area in yellow is showing you the highest incidence areas in the United States. And basically, when you look at this looks like a wildfire in the southeastern United States and New England seaboard. These are the areas now in the United States where HIV is considered at the highest rates and really the biggest problem areas. And a new concept to a lot of people that HIV is a major, major problem in the South, especially in the rural South and in the poor areas. Now let's look at our nation's capital in the District of Columbia. The prevalence in the District of Columbia is approximately 3.2%. There's a stunning prevalence in black males in the District of Columbia of 7.1%. Now, if that number doesn't mean a lot to you, let's put this in perspective of prevalence in Africa. The prevalence, just the general prevalence in the District of Columbia, 3.2%, is higher than the prevalence in Ethiopia, Rwanda, the Democratic Republic of Congo, and Sierra Leone. So this is clearly, I think, very disturbing that in our nation's capital we have the prevalence higher than approximately half of the countries in Africa. Now, in terms of the age distribution of who's living with HIV, this is a major change from 15 years ago. If you look at the age group that has the most number of people living with HIV now, it's the age group in the middle there, 45 to 54. We're soon approaching what we consider the 50-50 line, where approximately 50% of people living with HIV in this country will be 50 years of age or older. And this really signals a need for a lot of internists to get involved in primary care providers, because we're going to have a number of people living with HIV that have a lot of chronic medical problems and general medical problems associated with aging. Now, let's look at the incidence, or who's getting HIV and how many new cases per year. It's estimated in the recent years that approximately 50,000 new cases of HIV are occurring every year, so 50,000 new acquisitions, not just reported cases, but the number of new people actually acquiring HIV in the U.S. Who's getting HIV? Well, you can see that this male-to-female distribution is skewed even more in recent years. In terms of who's getting HIV now, about 4 out of 5 people acquiring HIV are males. Looking at risk factor acquisition, again, this is skewed even further in terms of a higher distribution of male-to-male sex. Almost 2/3 of people acquiring HIV now are acquiring it through male-to-male sex. Again, the female heterosexual is close to 20%, approximately 1 out of 5. And you can see the number that's dipped down even more is the injection drug use, which is now down to approximately 8%. But if you add in the male-to-male and injection drug use, it's probably somewhere around 10% of people acquiring HIV through injection drug use. Now, again, the incidence rate looks very similar to what you're looking at with the prevalence. And this is the estimated HIV incidence rate by race or ethnicity. And again, you can see that blacks or African Americans are by far disproportionately affected here. And this is really a huge issue that I think has taken a while to get out there in the general public, how hard this epidemic is hitting the African American community. Now, kind of putting this together in terms of what's happened over time, if you look at this graphic, it tells you a lot. The bottom bar down, the line there, is the number of new HIV infections that are occurring every year. This number in the past 10 years has been pretty steady, around 50,000 new infections every year. Now, fortunately, there's a lot fewer deaths than that. There's only about 10 to 15,000 deaths that are occurring every year that are attributable to HIV. But you can put the math together and see that if there's 50,000 new infections and approximately 10 to 15,000 people are dying, you've got an expansion of about 35,000 people per year in this epidemic. So the top graph there, people living with HIV, is what you would expect. We have a continual expanding epidemic. And in contrast, what many people think, this epidemic is not contracting, it's been expanding. The problem is not going away. Now, let me shift gears to what's new in terms of HIV testing and what's new in terms of the diagnostic algorithm. And I'm going to cover this, not to really get into a lot of nuances with some subtleties and false positive Western blots and things like this, or indeterminate Western blots, but I'm covering this because there's been a fundamental shift that the way that we do HIV testing is completely different than the way that all of you are familiar with how you've done HIV tests for years. So it's really worth going over. Now, one of the things that really I think is important to highlight is that in 2006, the CDC issued a landmark recommendation, which basically was to perform routine HIV screening in all patients aged 13 to 64 in all healthcare settings. Meaning whenever you see a patient in a medical care setting, you should order an HIV test at least one time. That was a recommendation that came out in 2006. Now, looking at this top bar here, you can see that in addition to this recommendation for screening age 13 to 64, it's very important to note that they do recommend for high-risk individuals that they continue to be screened on a regular basis, at least annually. In many clinics, for example, I know in Seattle here, we often are screening men who have sex with men approximately every 6 months for HIV, and sometimes even more frequently than that. Now, in 2013, the United States Preventative Services Task Force actually issued a similar recommendation, endorsed the CDC recommendations finally, with a very similar recommendation and a similar recommendation to do the follow-up testing at least annually for high-risk individuals. Now, then the question is, well, what's been the impact of this? And we think these CDC recommendations did have a big impact. They were a little slow for people to take these into account and to start more broadly testing. But I think it's important to look at the fraction of HIV that we call the undiagnosed fraction. So if you look in 2003 at the undiagnosed fraction, in other words, who's unaware that they have HIV even though they're living with HIV. In 2003, the undiagnosed fraction was estimated at 25%, and approximately 1 out of 4 people were walking around with HIV and did not know they had it. There's obviously some implications of that. Now, in 2011, the data looks a lot more encouraging. The estimates from the CDC in 2011 were this undiagnosed fraction had moved down to 14%, which is now approximately 1 out of 7 people living with HIV are unaware that they have HIV. And then you need to step back and say, well, what's the implication of that? What's the implication of somebody who has HIV and they don't know it? Well, first of all, if you don't know you have HIV and you're not getting any treatment, what typically happens over time is people get infected, they have a dip in their CD4 count, and over time they have progressive immunological decline, eventually developing AIDS when their CD4 count goes somewhere in the range of 200 or lower. Now, if you know you have HIV, all of these new drugs that I'm going to talk about that are extremely effective become available to you, and for your own personal health benefit, you can receive these drugs. So clearly, knowledge of HIV status can translate into health benefit for the person who's infected with HIV. The second issue is looking at what's the knowledge of HIV status and how does that correlate with the risk of sexual transmission. So awareness of HIV status was looked at in this meta-analysis of 11 different studies in the United States where they looked at unprotected anal or vaginal intercourse and found that those people who were aware of their HIV status were much less likely to engage in high-risk sexual behaviors, and there was an actual 68% decrease in high-risk sexual behavior. So knowledge of HIV status in general translates into people modifying their risk factor activities, in general, not always. Now, another way to look at this was several studies have looked at this, and this one that I'm going to show you is done at a time when the undiagnosed fraction was 20%, 1 out of 5 people didn't know they have HIV. So what these investigators and others have looked at is that those people who are undiagnosed, what role do they play in new transmissions? How big a component do they play? So this graphic is very illustrative, and it shows you that 20% of people who are living with HIV who don't know it are accountable for basically half of all the new transmissions. So lack of knowledge of your HIV status has a lot of disadvantages. Knowledge of your HIV status has health benefits, has prevention benefits, has a number of benefits. So then the next issue to address is how are we diagnosing people with HIV? Now, what's the most effective way to diagnose the most number of people that has the biggest benefit and in a cost-effective manner? Well, this was addressed after years of discussion and proposals in a formal recommendation that came out just approximately 6 months ago by the CDC. And this essentially was a revamping of our approach to the way that we do HIV testing. The conventional approach that all of you have done year after year after year, really since the 80s, is basically to order an enzyme immunoassay, which is a simple antibody test, and then if it's positive, you do a supplemental or confirmatory test with the Western blot, which is somewhat difficult for many people to interpret. You get a lot of indeterminate Western blots and so on. But then this year, this approach was completely replaced by a new algorithm or two new sort of basic tests that are used. So what is recommended now is a screening test that is called a fourth-generation antigen-antibody immunoassay. P24 antigen is why it's called antigen. The antibodies are either IgM or IgG antibodies. Then what's recommended is that if you have a positive screening test with this antigen-antibody immunoassay, you follow this up with what's called a HIV 1-2 differentiation immunoassay. Differentiation because it's differentiating whether or not they have HIV 1, HIV 2, or both. Completely new approach to how we're doing this. So let me run through a little bit about why the guidelines have changed and why this approach has changed. Well, fundamentally, the big issue gets around the window period. The window period is conceptually the time from a person who is infected with HIV until the time that they develop detectable antibodies in their blood. And this is approximately 25 days with sort of standard third-generation immunoassays. Now, a viral load test, either quantitative or qualitative, is much better in detecting early HIV infection. You can see this turns positive at approximately 10 days. So it closes that window period down. However, a viral load test is not an easy test to do on a screening basis. It's not cost-effective to do on a routine sort of primary care basis. So we don't use that as a primary screening tool. What looks to be a fairly good compromise is the P24 antigen, which falls in somewhere between the viral load and the antibody and closes the window down significantly, but not quite as much as the viral load. But it's a very good, cost-effective, reasonable approach to trying to actually shut down this time period, the window period, where you could see someone, they could recently have acquired HIV, and you order a standard antibody test and you miss it. You miss that they just recently acquired HIV. So in case you're not familiar with P24 antigen, just to remind you, the P24 antigen is really the critical protein and structure that makes up the viral capsid or core of the virus. And it's really just these P24 antigens are just basically placed together in a lattice-like format to make the core, the outer capsid of the virus. Now, how is this test, this fourth-generation antigen-antibody assay done? So the basic principle is, that's different than the other tests, is this assay has what we call a P24 capture antibody. So what it's capturing is the antigen if the person is infected with HIV in their blood and they have antigen. It also captures it has these recombinant proteins that will capture the patient's antibody. So what it looks like is if the person has P24 antigen in their blood, it will capture that, and using an immunoassay, it'll light it up. If the person has IgM or IgG antibodies, it will capture those through these recombinant proteins. So what's different about this test is that it actually detects direct viral products and the host immune response to the virus. So you've got a viral product detection and you have an antibody detection from the host. And that's what makes this test fairly unique. Now, the bad news is, if the test trips positive, it's an immunoassay, the light changes, the color changes, you don't know what tripped it. You don't know if it was the antigen that tripped it or if it was the antibody. And that's the single factor that I get called about or asked the most about from a primary care provider standpoint, is that test is positive and people are trying to say, well, do they have acute HIV? And you can't tell from just looking at that assay. You just know that it's trip positive. If you've not seen these these differentiation assay, the one that's commonly used out there is called the multi-spot. It's called multi-spot because it has 4 spots on the actual test when you do it. It has a control. It has 2 different spots that actually detect HIV-1, 2 different methods, and it has an HIV-2 peptide that will detect HIV-2. So what you find out from this test, if the screening test with the antigen antibody was positive and you go on to this, you find out, do they have HIV-1, do they have HIV-2, or do they have both, or do they have neither? So this is what the CDC algorithm looks like. And just briefly to walk through this. We screen now with this 4th generation antigen antibody assay. Most labs now reflexively know to go down this pathway and you don't have to do anything. If it's negative, you're essentially considered done unless you think they just had an exposure maybe 10, 15 days ago. But otherwise, you're done at this point with your screening test. If the test is positive, you move on to this multi-spot that I just showed you, and that will tell you, do they have HIV-1, do they have HIV-2, or do they have both? Now, interestingly, sometimes you get a test that trips positive here, and then the differentiation assay is negative for 1 and 2, and then you've got to be thinking, whoa, did we catch them in that window period with the P24 antigen? That's what tripped the test. So then you go on and you do a viral load test, which is the very best way of detecting early HIV. And if that's positive, you then just found somebody with acute HIV. And there are huge implications from this. And they've been able to show this in a number of sort of rollout, that this test has actually done a pretty good job at increasing the detection of people with acute HIV. It's not perfect, but it's done a good job. Now, if the test is negative, then you're kind of really stuck because you go, well, what happened here? And you really don't know, but probably it was a false positive screening test, and you kind of go back to the drawing board and repeat things again. You look at how high a risk the person had, putting all this together. Now, stacking all this up, what a lot of people really want to know is, okay, when do all these tests turn positive after a person is infected? So the earliest is the HIV RNA, which is about at day 10. The next that trips positive is the 4th generation, tripping positive because of the P24 antigen. Then a standard EIA turns positive about 23, 25 days after infection. Now, the rapid tests, which were very popular 5 or 6 years ago, really aren't as good. They don't really trip positive until about day 30 or 35. And really the worst is the Western blot, which doesn't detect till out to probably 35 or 40 days. So you can look at this graphic and it makes a lot of sense that you see why we're doing what we're doing now, which is screening with the test that does a much better job of detecting, and you have the additional benefit with this algorithm that you're actually detecting and sorting out whether or not they have HIV-1 or HIV-2. And for many of you that are not familiar with HIV-2, that's predominantly acquired in Western Africa. We do have some cases in the U.S., although we really don't know how many cases because we haven't been screening for it widely until very recently. Now, what's the implication then of finding someone with acute HIV? These implications are really huge. This is a study that just came out about a month ago, generated a tremendous amount of attention, and these were investigators that basically concluded that deferral of antiretroviral therapy beyond 12 months of the estimated date of seroconversion diminishes the likelihood of restoring immunological health in HIV-infected individuals. There's a growing trend to really feel that the earlier that you can find someone and diagnose them, there's a benefit for that person not having permanent immunological damage. Now, secondly, from a transmission standpoint, this is a study that looked at the probability of transmitting HIV per coital act over time. And looking at this graphic, you can see that right after a person's infected, their risk of transmitting HIV is sky high compared to how this looks later on down the road. So people with acute HIV are considered to be so-called hypertransmitters or supertransmitters, and it's probably a multifactorial cause. The basic idea is that, number one, they don't know they have HIV, and they obviously just got it engaging in something that was a high-risk behavior, so they're more likely to be doing this in the next time period, in the next month. Secondly, it's very clearly established that with acute HIV, these individuals have very high viral loads in their plasma and very high levels in the semen, the anal vault, the vaginal area, wherever you look. People have sky-high viral loads when they're first infected. And third, and this is a little bit complicated from an immunological standpoint, but when a person is first infected with HIV, they tend to be infected with one strain of the virus. They don't get infected with 40 different strains and they all go off to the races. There's usually one winner that's a strain, and that strain is very fit to transmit. So when a person has just been infected, what starts dividing in their body is a homogeneous population of very fit transmissible virus, so they are more likely to transmit these on to other individuals. Okay, now let me shift gears and put the framework of antiretroviral medications. And again, what I'd like to do for this is try and put this in perspective so that people don't feel overwhelmed by the medications. I'm not going to go into a lot of research studies and complicated issues related to antiretroviral resistance that we deal with all the time in the clinic, but more the general broad sweeping, how do you understand the medications and the general approach to this? Well, the first thing is the antiretroviral medications are the single biggest factor that have turned this epidemic around. It is indisputable that the medications made this dramatic benefit. When they were introduced in the mid-1990s, the death rate from HIV plummeted. There is no other explanation, and there's multiple studies that have clearly linked this dramatic fall-off with the widespread introduction of what we call combined or highly effective antiretroviral therapy. Now, to kind of put this in perspective for what the benefit is in people who take antiretrovirals who don't, there's a recent study, it just came out in PLOS ONE, that basically looked at this and said a person who does not have HIV has a lifespan somewhere around 79 years, approximately. If you take a person who gets infected with HIV at age 20, their lifespan is only about 32 years. It's a dramatic cutoff in their lifespan if they don't take antiretroviral therapy. However, you take that same person, you give them antiretroviral therapy, and you can see that their lifespan starts to normalize almost to a normal lifespan. And this is really good news. Now, there's a lot of other issues with chronic HIV that we'll get into a little bit later, but clearly antiretroviral therapy changes the overall outlook for people. Now, what is it that we're actually using with these medications? And again, this is somewhat complicated if you don't do this, but the basic idea of what we do is that we use a backbone that has two nucleoside reverse transcriptase inhibitors, and we combine this with so-called anchor drug, which is a highly potent third drug, a non-nucleoside reverse transcriptase inhibitor, an integrase inhibitor, or a protease inhibitor. And I'll go through the mechanisms for all of those classes in just a minute. Now, before really diving into the mechanisms, it's important to step back and sort of look at what does it look like in the day of HIV? In the life of an HIV, what does its day look like? Well, what HIV basically does is it binds to the cellular co-receptors, CD4 and then the co-receptors, enter the cell by fusing with the membrane. Basically, the P24 capsid dissolves. The HIV RNA is converted to DNA, enters the nucleus of the host cell, and this is usually a CD4 cell, stitches into the host DNA, RNA is made, proteins are transcribed, the virus moves to the membrane, takes off the membrane of the host cell, and goes on and infects other cells. That's sort of the day of an HIV virion. Now, what the virus actually does is it takes this cell and it turns it into a factory that is just cranking out innumerable HIV products, and eventually, because it's using up all of the materials of the cell, it kills the cell. Now, where do these different classes of drugs work? The first site is the entry inhibitors. I'm not going to discuss these in further detail. We do use these in clinical practice, but they're not routinely recommended when we start people on antiretroviral therapy. So I won't go over those any further. I will focus on the reverse transcriptase inhibitors, and there's two different classes here, the nucleoside and the non-nucleoside, the integrase inhibitors, which work at the level of the nucleus, and the protease inhibitors. Okay? So let's take a look at these. Now let's dive into the reverse transcriptase inhibitors. The enzyme is the reverse transcriptase. The step that we're looking at trying to halt is the conversion of RNA to DNA, and this occurs prior to the virus moving into the nucleus. And the two classes that we're going to look at and differentiate in terms of how they work are the nucleosides and the non-nucleoside. This is, in clinical practice, usually misunderstood. What's the difference between a nucleoside and a non-nucleoside? It's very important to understand the fundamental principle of what HIV is doing in terms of reverse transcription. This is a cardinal principle of retroviruses, which HIV is. This is converting RNA into DNA. As humans, we don't do that. We don't take our DNA and convert it into RNA. This is a retrovirus principle. It converts RNA into DNA. Now, the key enzyme in this is the reverse transcriptase enzyme. This is a heterodimer with a P66 component, a P51 component, and a critical polymerase active site, which is the action area for the virus as it's converting, for the enzyme as it's converting RNA to DNA. And what you see here is the RNA threading through this active polymerase site as the conversion of RNA to DNA occurs. And drilling down a little bit further, what the virus is really doing is that it is taking the human building blocks, the nucleotides, it's a mooch, it's taking them and it's adding them on one by one to the RNA, and it's converting the RNA into DNA with basically this reverse transcriptase enzyme mechanically putting all of this together. Now, how do the nucleoside reverse transcriptase inhibitors work? This is the drug AZT, tenofovir, emtricitabine, abacavir, all of these drugs, if you're familiar with those. These drugs work because they are synthesized to look like the human nucleotides. If they are triphosphorylated, they then can be picked up by the reverse transcriptase enzyme and placed into this elongating chain. However, they are structurally built in a way that they do not allow elongation of the chain. Think of them as like caboose molecules. There's nothing that's added on after that, and what you get is so-called chain termination. So these drugs are mimics, they're decoys, they are not directly inhibiting the enzyme, they're acting as a decoy and they're fooling the virus. But they have to be triphosphorylated first. Now, the non-nucleosides have a completely different mechanism of action. Basically the same area, same enzyme in terms of what's happening, but what the non-nucleosides do is they bind to this NNRTI binding pocket, and once the NNRTI binds, what you have is a hyperextension of the thumb region, which exposes the active polymerase site, making it unable to thread the viral RNA through. So that's how the non-nucleosides work, and as you can see, it's a completely different mechanism of action. The nucleosides are decoys, the non-nucleosides directly bind to the viral enzyme and alter the shape of the enzyme. Let's turn to the integrase strand transfer inhibitors, and there's tremendous interest in the field right now for the integrase strand transfer inhibitors because they are an extremely effective class of drugs. The action here involves the integrase enzyme. The location is at the nucleus of the cell, and the integrase inhibitors are really a class that is expanding very rapidly because they have many ideal properties. The actual integrase enzyme exists in three basic forms. It exists in a monomer form, a dimer form, and a tetramer. And the dimer form is the form where that originally bind to the DNA. Essentially, they splice open a little end of the DNA, make a sticky end. They add this essentially a component here on the end, and once they're attached to the DNA, they then approach the host DNA with the idea that they're going to essentially bind to the host DNA, splice it open so that they can stitch in or transfer the strand of the viral DNA into the host DNA, which is what happens. It splices it open, the strand is transferred. Once that process is complete, the virus is then integrated into the host DNA and is then referred to as so-called proviral DNA. Now, this is huge because this is the single reason we can't cure people with HIV. It's on your hard drive. You get HIV and you get the virus integrated into your cells, it is on your hard drive. You cannot get rid of it unless you get rid of all the cells that are infected. So any process to prevent integration is considered very important, and people are very interested in this, thinking about cure if you could prevent integration. Now, the integrase inhibitors bind at the enzyme active site. It's a catalytic site that is the key site that splices open the host DNA. And the basic idea is that once you bind to this area, this catalytic site is rendered inactive, and you're just not able to splice open the host DNA. And those are called integrase strand transfer inhibitors, but we really refer to them short in the clinic usually as integrase inhibitors. Last, let's look at the HIV protease. This is where the action is with protease inhibitors, but protease actually has multiple sites, including proteolytic processing of the GAG-Pol polyprotein, the GAG protein, and this is particularly important as the virus is leaving the cell and budding off to infect other cells and maturing. This enzyme basically exists in 3 different conformational forms: in an open form, a semi-open form, and a closed form. And looking at this visually, you can imagine that this is like a molecular scissors or molecular meat cleaver that when it closes, it causes proteolytic processing. And indeed, the 2 major targets for the HIV proteolytic processing for protease are the GAG-Pol polyprotein, which is made up of a couple structural proteins, matrix and capsid, and these enzymes, protease, RT, and integrase, and the GAG polyprotein, which are all structural proteins. What happens is that the protease cleaves itself out of the GAG-Pol polyprotein. Once it's released and free, it's then off to the races to begin its GAG-Pol polyprotein processing and the GAG processing. Now, in terms of looking at what actually happens when the virus is maturing, these GAG polyproteins are shown here, and then schematically in here basically a schematic of a viral maturing particle. And what happens is these GAG polyproteins are anchored into the cell membrane circumferentially around the virus, and as the virus starts to mature, the protease begins its action, starts to cleave all of these different areas that are these structural proteins, releasing all of these structural proteins to then move to their preferred place in the overall structure of the virus, and that's how you get the formation of a mature viral particle. So protease plays a critical role in the late processing and maturation of the viral particle. And then, as would be expected, if you are able to block this enzyme, which is what we do with protease inhibitors, they bind right in the center of this, at the active protease inhibitor binding site. And think of this as like jamming up a pair of scissors. What you do is you then prevent the active proteolytic processing, and what leaves the cell looks like a virus, but it's so immature because the GAG proteins haven't been processed and they can't go on and structurally infect other cells. Okay, now back to the different drug classes. So again, the backbone drugs, we tend to use 2 nucleoside reverse transcriptase inhibitors, and then they're one of these anchor drugs. Now, specifically, what type of drugs are we using? Tenofovir M-tricytidine and abacavir lamivudine are the 2 backbone medications. And the anchor medications, there are a number of those, including the non-nucleoside. Of these 2, we usually use efavirenz. There's 3 different integrase inhibitors that are frequently used: raltegravir, elvitegravir, boosted with a pharmacological booster called cobicostat, and dolutegravir. And then there are 2 protease inhibitors that we use, and these are the recommended drugs when we initiate therapy, are darunavir and atazanavir, and they're boosted with ritonavir. So just to clarify then, this sort of schematic of these drugs are the drugs that are preferred at the time you're initiating therapy for patients. Now, what's very popular now are the combined single tablet regimens, and the idea here is that you are combining these 2 backbone medications with an anchor medication, and what you get are some of these very popular single tablet regimens. It's very hard to believe that you can take a single tablet now for HIV, and that is just as effective or even more effective than what we were using years ago to treat HIV with multiple different medications. Now, what are we looking for at the time we start antiretroviral therapy? We're hoping that when a person starts on therapy, their viral load will rapidly go down. And this is a so-called undetectable viral load, or less than 50 copies. And I won't go through the details of a lot of studies, but basically we're trying to get somewhere between, in these studies, that 80-90% of people have an undetectable viral load. That would be a very good result in the studies. And in these new pills, for example, the single tablet regimen, you can see in clinical settings have performed very well, and in research settings, they have generated undetectable viral loads of less than 50 copies, and somewhere in the range of 80-90% of patients. As shown here with 2 other single tablet, well, this is actually also with Atripla again, and the medication Stribild. These medications have really been very good. So it's hard to really conceive that these single tablet regimens are really highly potent, highly effective, and very well tolerated. And just to finish then in terms of this section, What really we have now available to us in clinical practice are these multiple regimens that are recommended now for initial therapy. And for the patient, this is what they see. They see a pretty low pill burden now, no matter what regimen that we choose as one of these preferred regimens. But we frequently now in the clinic, because of patient requests, are using these single tablet regimens. And that's a big trend in the field of HIV. Now, let me shift gears and look at the timing of why we're initiating therapy earlier. So the timing of antiretroviral therapy is frequently really dictated to us in a general practice by these national guidelines. They're excellent guidelines, the Health and Human Services guidelines. And these guidelines address when to start antiretroviral therapy. And this CD4 decline, when do you pull the trigger in terms of what's the CD4 threshold? Currently, the recommendation is antiretroviral therapy is recommended for all HIV-infected patients, regardless of their CD4 count. This is a huge deal. That means everybody should be treated who has HIV. It has not always been that way. You can see here looking over time, we've started to use antiretroviral therapy earlier and earlier. Then in 2012, we reached the same recommendation we have now, which is to treat everybody. The big question is why? Why are we treating everybody earlier? Why is there a recommendation out there to treat everybody? And this is a really important concept in HIV, and I'll run through the major factors. Well, first of all, antiretroviral therapy in 2014, 2015 looks completely different than what we were doing in 1996. And as I said, you now often see patients in the clinic getting prescribed one pill once a day that's very well tolerated, very effective. There's a low barrier then for wanting to give antiretroviral therapy from that standpoint. The second is there have been a number of studies, most importantly the landmark study done by Mori Kitahara and her colleagues that was published in the New England Journal that showed a significant survival benefit with early therapy when they looked at all-cause mortality. So not really benefiting in terms of less AIDS, but all-cause mortality, there was a benefit in starting therapy earlier. And historically, we've always thought of AIDS as more of just an immunological decline disease, a progressive immunological decline with immune deficiency. Indeed, HIV does that. But the new concept in the field of HIV is this idea that HIV also has a dual problem of causing immune activation. And conceptually what happens is that after a person's infected, there's this tremendous immune activation or dysregulation that crescendos over time without treatment, and it's clearly different than in people who are not infected with HIV. This immune activation is associated with significant consequences: increased myocardial infarction, stroke, and cancer. And just to show you some data that backs this up and why we believe this is a veterans aging cohort study performed in 2003 to 2009, which basically found that people with HIV, after matching for all Framingham variables and everything, people with HIV have about a 50% increased risk of having a myocardial infarction compared with those that don't have HIV. This risk is even higher if their viral load is not controlled compared to those that are controlled, and it's even higher if they have more immunological decline, low CD4 count versus higher CD4 count. Now, if you look at different age distributions, you can see that this same effect, the HIV infected is in red, the uninfected is in blue, looking at cardiovascular risk. This is a major differential as you move into the age 50 to 59 and 60 to 69, as would be expected, and underscoring this issue that as people with HIV live longer, we're going to be dealing with more of these types of problems. Now, just to kind of put this in perspective of other risk factors, the HOPS study looked at this and tried to place this risk of HIV in a CD4 count less than 500 relative to other cardiovascular risk factors, and basically it came out about the same as smoking. So what we think now in the field of HIV is HIV itself really is equivalent to a cardiovascular risk factor. So we need to take that into account when we're talking about managing lipids and dealing with patients in terms of their risk. Now, to understand this immune activation, this immune dysregulation, it's important to look at the gut-associated lymphoid tissue, which makes up 20-30% of the entire lymphoid tissue, and the intestinal microbacteria, and how these two interact. Now, if you look at the gut area in a person who does not have HIV, and this is just sort of a small bowel lining, you can see that it is very rich with these CD4 cells as shown in blue under the intestinal lining, and there's a fairly abundant CD8 cells, and there's also dendritic cells. And this is the so-called gut-associated lymphoid tissue, or GALT. What happens with acute HIV infection is there is abrupt and there is massive destruction and fallout of the CD4 cells in the gut. Profound fallout. Now, if you look at this either by endoscopy or histologically, you can see this. This is a person who does not have HIV. Notice all the big lymphoid aggregates inside the intestinal lumen. Acute HIVs are essentially not visible. Histologically, the yellow staining, silver gold staining, are lymphocytes, CD4 lymphocytes. They're basically decimated after acute HIV infection. And unfortunately, much of this damage is permanent. Now, what's the fallout from that? Well, in a normal, healthy person, the gut lumen serves as and the gut itself serves as an excellent mechanical and immunological barrier to bacteria. As I've shown with HIV, with a very disturbed gut area, you have the so-called leaky gut because of the structural damage, and you also have this microbial translocation that occurs and a very poor immunological capability of controlling these local tissue mycobacteria, or these tissue microbes that come in through this leaky gut syndrome. What does this mean in terms of the overall pathogenesis? So putting this together, the sort of prevailing pathogenesis theory is that with early HIV infection, there's massive and major CD4 destruction. This leads to some structural damage, leads to gut permeability that's increased. It leads to a decreased gut immunity. And unfortunately, this leads to a lot of uncontrolled bacterial translocation, which spills into the systemic system with increased bacterial lipopolysaccharides, especially from gram-negative organisms, which leads or stimulates this chronic inflammatory response. Now, we believe it's much more complicated than this, but this is at least one of the main theories. And there's a great deal of interest trying to figure out how do you actually restore the gut, and have not been successful in figuring this out. So the good news is that if you treat people with HIV, you do improve this dysregulation and immune activation, but you probably don't restore people back to a level of normal immunity and immune regulation if they didn't have HIV. Now, the last issue to address, why we're giving therapy earlier, and probably the most important, is the concept of HIV treatment as prevention. And the notion here is that you take people who have HIV, you're going to treat them for their health benefit, but also what happens in terms of their risk of transmitting to their partners or other individuals if they are on antiretroviral therapy. And what you see here in this particular study, which is a landmark study called the HPTN 052 study, this looked at heterosexual discordant couples, meaning one person in the couple had HIV, the other did not. This was mainly heterosexual couples, a few gay couples in this, 13 international sites, more than 50% of people in this were in Africa. What they found, or what they did, was they randomized people to receive therapy either earlier with a CD4 threshold of 550 or later at a CD4 count of 250. And at the time they did this study, antiretroviral therapy was not being given at really early time periods globally. And what they found was dramatic. They found that those individuals that got early therapy, only one linked transmission to their partner occurred. And the people that deferred therapy and were not on antiretroviral therapy, there were 27 transmissions. This was a 96% reduction by antiretroviral therapy. Profound effect of prevention taking antiretroviral therapy. This has been looked at in a community level, and there's a lot of research going on in this area, and this is in San Francisco, where they looked over a 5-year period. They looked at the community viral load based on reporting data, and they compared this with the number of new infections, and they saw this trend that as the community viral load went down, you started to see less infections. And there are a number of different communities and areas now that are really looking at this on a more aggressive fashion. So then there's a number of things then that really have led us to try and use antiretroviral therapy for everyone, including the dosing is much more convenient, much better than what we had in the past. There's a survival benefit with early therapy. HIV causes this immune dysregulation and immune activation that we'd like to try and minimize the damage of that. And last but not least, HIV is profound preventer of transmission. Antiretroviral therapy, I should say, profoundly prevents transmission. Now, let me shift gears to HIV-negative individuals and the concept of PrEP, which I would argue now we're in an early phase of. And don't give up on PrEP now, even though some of the results have not all been successful. But let me walk through the basic concept of PrEP. The basic idea behind PrEP is that you take high-risk HIV-negative individuals and you put them on a daily dosing of an antiretroviral medication. And they are then taking what we call pre-exposure prophylaxis. And the idea is that you have them protected before, during, and after any HIV exposure event. And that's the concept behind PrEP. Now, let's look at where the action is. Let's look at the actual genital mucosa, and let's look at what's going on there with PrEP. Now, the normal healthy genital mucosa, beneath that in the tissues, there are the targets for HIV. The CD4 cells, most importantly, dendritic cells, and macrophages. When a person is infected with HIV, as I mentioned, it's usually one or two strains that actually are sort of the winners that get through and actually make the transmission occur. And this is just showing you the virus reaching the target cell, the CD4 cell, and then rapidly expanding. What you're hoping to do with PrEP, and the most common agent that's used in the PrEP studies has been tenofovir emtricitabine, or Truvada, is you're hoping a person takes this on a regular basis, they get good levels in their blood, which translates to good levels in their tissues, and their target cells are then loaded up with these reverse transcriptase inhibitors, tenofovir and emtricitabine. If then the person has an exposure event, what you have, hopefully, is the cells loaded up, so if the virus does enter the cell, when it reaches the step of viral RNA conversion to DNA, it's blocked by these two reverse transcriptase inhibitors, and that's the idea behind PrEP. If you don't have the drugs on board, this is not going to be effective. Now, looking at several different studies for PrEP, the first one that got a lot of attention was a so-called IPREX study, where they looked at approximately 2,500 men, and they gave them PrEP. They randomized to either receive tenofovir emtricitabine or placebo. And these were men who were having sex with other men and were considered very high risk to acquire HIV. And what did they find? They found that those individuals that got randomized to receive tenofovir emtricitabine had about a 44% reduction compared to those that received placebo. Good results, but not a home run for sure. Now, a follow-up study looking at heterosexuals that was done and led by Jared Baton here at the University of Washington was a so-called Partners in PrEP study, which was performed in Kenya and Uganda. And what they did here is they looked at serodiscordant couples. And now, in contrast to the 052 study that I mentioned earlier, now we're talking about giving antiretrovirals to the negative partner. So what we're looking at is that if you gave antiretroviral therapy to one of these negative partners, did it have a big prevention benefit? And what they did was they randomized these negative partners to receive either placebo, tenofovir, or the dual therapy of tenofovir emtricitabine. And what they found was a major reduction. Those individuals that took tenofovir had a 67% reduction. Those that received tenofovir emtricitabine had a 75% reduction. So very encouraging findings. Now, just kind of putting these different PrEP studies together, there are 5 major studies to mention that have used oral tenofovir emtricitabine, which is what is being used in the U.S. right now for PrEP. The Partners in PrEP I just mentioned, about a 75% reduction. Another heterosexual couple study done by the CDC called the TDF2 study showed a 63% reduction. I mentioned the study in men who have sex with men, the IPREX, 44%. And 2 studies done in women, the FemPrep and the VOICE trials, had disappointing results and really negligible benefit with the use of oral tenofovir emtricitabine. Now, if you look, however, at further analysis based on drug levels and adherence and estimates of adherence based on who was actually taking the medications, you get a little bit different story. You can see that the actual efficacy among those that were actually taking the meds with PrEP was really pretty good. And you can see from the FemPrep and the VOICE trial, the adherence was very low. So I think it's very difficult to make any conclusions to say this didn't work because there was inadequate adherence with that. Dr. DiMarazzo, who's here today, may want to answer any questions about that as well because I think the adherence piece of this is really critical. So now, looking at what's recommended in the U.S. right now, pre-exposure prophylaxis recommendations came out from the CDC in May of 2014. These recommendations from the CDC basically said the following. Evaluate people who you think are high risk for acquiring HIV, and if you deem this person has substantial risk of acquiring HIV, consider using PrEP. This is for men who have sex with men, heterosexual men and women, and injection drug users, who I'm not going to talk about because I'm emphasizing sexual transmission right now. But the idea is that for all of these different risk groups, daily tenofovir emtricitabine is what's recommended. There are other strategies looking at more intermittent PrEP, but I won't go into that because none of those have been published at the present time. There are a number of barriers with PrEP. There's a lot of concerns about the adherence issue, the cost issues, safety concerns, and the prescriber. And before deeming this really isn't, who's going to be prescribing this, I just want to underscore that we're really, I think, in the early phases of understanding how to optimally use PrEP. And with antiretroviral therapy, when it first rolled out, it wasn't all successes initially. So I think we really shouldn't be giving up on the possibility. We should really be thinking about PrEP as a major tool, as an HIV prevention tool. Now, just in closing and sort of looking ahead at where we're at, I really underscored that it's really disappointing that we haven't seen a major fall-off in the number of new HIV infections. It's disappointing that we continue to have an expanding HIV epidemic. And I think the question is, what's going to happen in the next 15 years, out to 2030? Clearly what we want to happen and what the goal should be is to actually see the number of new infections start to fall off significantly, which would finally lead us to a contracting epidemic. Now, how to achieve that is very complicated and kind of beyond the scope of this talk, but let me underscore a couple of key aspects of how we could achieve this. One is routinely performing HIV testing is very important. Repeat testing for people who are high risk, understanding the epidemiology and knowing who repeat testing should be performed on. Treat all HIV-infected individuals from a health benefit and from a prevention standpoint. And last, we have to do a number of things to figure out better ways to keep people retained in care. And in addition, I think there's much to be learned about the optimal use of PrEP and how we might be able to integrate this more widely in clinical practice in the U.S. as a major prevention tool to make the number of new infections go down. Now, the last thing to mention is that I showed this graphic about people living out to 71 years. And I just want to emphasize this is really going to bring a new era of chronic care for HIV with older individuals. And it really signals the need for more internists and primary care providers to get interested and involved in HIV care and to play a major role in the future of HIV care as we're really looking forward into sort of the next wave and way we deal with and treat HIV. So what I've done today is I've tried to run through some what I think are important new issues related to the diagnosis, the treatment, and the prevention of HIV. And I hope some of these provide further insight, motivation for you for HIV in 2015. So thank you very much for your attention. Thank you.